And I would like to welcome all the participants in this ICA webinar, which is become a hallmark of Indian College of Anesthesiologists. Every Wednesday, 7 to 9, without fail. We have been doing this for last 3 years now. And today is the 159th webinar, and I welcome all of you to join us in our progress and progress to the goal of patient-centered care and sharing of knowledge and other useful items which are necessary in the day-to-day practice of our clinical care. Today we will be dealing with the subject of renal dysfunction in critical care. It's a very important aspect of care of patients because as much as 30% of patients in critical care units have renal dysfunction. And before that, I would like to give a salient features of the Indian College of Anesthesiologists. We conduct various fellowship programs, and the recent addition to this family of fellowship programs is the critical care echocardiography, which has become quite popular. And we publish Yearbook of Anesthesiology every year, which is of a quality material. And the annual conference of the ICA, which is called ICA Con, this year, ICA Con 2023, will be held in Bengaluru from the 2nd of November to the 5th of November. Please join us. And if you want to become a member of ICA, please visit the website. The membership forms are available. We'll be happy to take on the memberships. Coming to the subject proper, the renal dysfunction and critical care, we have 3 leading intensive care specialists with us. Dr. Sanjay OP, who is the in charge of the adult intensive care unit in the cardiac side at the Narayana Hrudayalaya, Bengaluru. Very prolific speaker and experienced in the intensive care management of critically ill patients. Second panelist cum moderator is Dr. Hemanth, who is currently the president of the Bangalore chapter of FIAS, Indian Society of Critical Care Medicine. He is the lead consultant in critical care at the BGS Global Hospitals. Again, a very straightforward, no-nonsense intensivist with a lot of skills and knowledge to share. And the third panelist, moderator, is Dr. Somnath Chatterjee, again a brilliant intensivist from Bangalore. I welcome all the moderators, panelists, to take us through this subject and make a useful evening out of today's 2-hour session. With these introductory words, I would like to invite Dr. Sanjay OP to take over from me and introduce the first speaker, and then onwards carry on with the proceedings of this meeting. Thank you so much for joining. And please stay till the end so that we can have a reasonable discussion at the end of the session. And thank you so much. Dr. Sanjay Orathi, as I said, is the Chief of Adult Intensive Care Unit in the cardiac side at Narayana Hrudayalaya. Dr. Sanjay OP, please.
Thank you, sir, for the introduction. Welcome all and good evening for this next webinar. And we will be trying and touching on most aspects of renal care in the intensive care unit in the post-operative period. I would like to welcome Dr. Siddharth Raju to give the opening lecture. Dr. Siddharth is an associate consultant who's been working with us at Narayana Hrudayalaya for a couple of years. He is well versed with renal therapy, and I would request him to open his talk, please.
Thank you for the introduction, sir. Good evening. It's my honor to speak to all my teachers, professors, seniors. It's an honor to speak to all of you. Today's topic is renal dysfunction and critical care, an insight into pathophysiology and treatment modalities by Dr. Siddharth. First, Kidneys are a very important organ in the body. They play a major role in maintaining the blood homeostasis, like total body water, total electrolytes, everything. So they play a very important role in the body. They are an indirect indicator of perfusion of the body based on the urine output produced. The functional unit of a kidney is called nephron. Almost person has 2 kidneys, and totally 1 million nephrons are there in our body. So the basic structure of a nephron, briefly, it consists of an efferent arteriole, followed by the glomerular capillaries, and followed by the efferent arteriole, then the Bowman's capsule, then that continues as the proximal convoluted tubule. As you can see, the proximal convoluted tubule has brushed borders. Then this proximal convoluted tubes continues as loop of Henle, as you can see. Basically, the descending limb, the loop, and the ascending limb, and that continues near the as the distal convoluted continues the ascending loop of Henle and forms the macula densa. Macula densa, and then it continues at the distal convoluted tubule and then into the collecting duct. This is the basic structure of the glomerulus at the level of the macula densa level, where you have the afferent arteriole, glomerular capillaries, and then continue the efferent arteriole, then the proximal tubule, and then these are the macula densa cells. The general functions of the kidney. They regulate the ECF volume, regulation of electrolytes, regulation of blood pressure, regulation of pH, acid-base balance, excretion of waste products, urea, creatine, ammonia, and other products. Endocrine function is renin, erythropoietin, and active vitamin D production. Degradation of hormones, that is insulin, forms insulinase and cleaves it, and or parathyroid hormone also. How the kidney plays the role in maintaining the total body water of the body. There are 2 methods, one by fluid intake and next is by regulating the excretion of water, which is again controlled by the antidiuretic hormone and by maintenance of the hyperosmolar medullary interstitium. How this medullary interstitium osmolarity is maintained, this is mainly called the countercurrent multiplier system, where high osmolarity is maintained within the medullary interstitium. How does it act? At the step 1, at the level of the descending loop of Henle, the high osmolarity within the tubule is because of reabsorption of water into the interstitium. That is followed by step 2 at the descending thin ascending loop of Henle, where the osmolarity decreases as it goes up because of the reabsorption of sodium and chloride. Then at the step 3, that is thick ascending limb of loop of Henle, where the active transport of sodium and potassium occurs by co-transport of potassium and chloride, and then into step 4, where the osmolarity is again reduced because of reabsorption of sodium and chloride, also reabsorption of water due to the presence of ADH, that is at the level of collecting start of the collecting the duct. High osmolarity and the pH is regulated by reabsorption of water in presence of ADH and reabsorption of urea. As you can see, the osmolarity at the level of the glomerulus to the loop of Henle keeps on increasing. It starts with 300 milliosmoles and goes up to 1,500, 1,200 to 1,500 milliosmoles at the level of this one, loop of Henle. This is the simple this thing representing the countercurrent mechanism and exchanger also, where the role of vasorecta and along with the tube of loop of Henle. The direction of flow in both are in opposite direction. As you can see, the proximal tubule, as the tubular fluid enters, it's 300 milliosmoles. Water gets absorbed. The osmolarity increases to 600. When it reaches the loop of Henle, it reaches 1,200. Then it's again there will be reabsorption of solutes. Then as it moves up, when it reaches the distal tubule, it is back to 300. Why all this happens is, as and when the interstitium, the solutes are absorbed, the descending limb of the vasorecta, they absorb the solutes, and as the vasorecta go down, that the descending limb, of vasorecta. This solute gets reabsorbed and the osmolarity increases in the vasorecta. Again, at the loop of the vasorecta, it is 1200. And as it goes up as the ascending vasorecta, it absorbs water from the interstitium which is absorbed from the descending limb of loop of Henle. Then when it reaches the level of glomerulus, again it is back to 300. Now we come into the important part, that is acute kidney injury. Acute kidney injury is very common in the critical care setting. It occurs in at least 30 to 40% of cases in critical care nowadays. And it is defined as any increase in serum creat more than 0.3 or 26.5 millimole per within 48 hours, or increase in serum creatinine 1.5 times the baseline, which is known or presumed to have occurred within the last prior 7 days, or urine volume of 0.5 ml per kg per hour for 6 hours. What is the traditional classification of acute renal failure or acute kidney injury? It is divided into pre-renal, intrinsic renal, and post-renal. Pre-renal, it's basically because there will be fall in the systemic blood pressure, or which might be due to decreasing the effective circulating volume. Along with that, which causes hypoperfusion, then it might either cause renal ischemia, or it might cause drop in glomerular filtration, and hence causing the acute kidney injury. The most common causes are intravascular volume depletion, dehydration, and hemorrhage, decreased cardiac output like congestive heart failure and myocardial infarction, systemic vasodilatation like when it occurs with anaphylactic shock and sepsis. This pre-renal failure contributes almost 55 to 60% of acute kidney injury cases. Then we go to the intrinsic renal failure, where which accounts for around 30 to 40% of cases. The cause of intrinsic renal failure is due to the damage to the kidney per se, which might damage the glomerulus or the tubules for various reasons, like there might be diseases of the renal like acute glomerulonephritis, or drug-induced injury like NSAIDs or antibiotics, which might damage the tubules or the glomerular basement membrane, or even rhabdomyolysis. Then this disease of interstitium and also toxins together cause acute tubular necrosis and hence cause the acute kidney injury. Possible causes miscellaneous renal diseases and toxins. Post-renal failure. Post-renal failure contributes for only 5% of acute kidney injury cases, which basically attribute to obstruction of the urine flow tract, which causes a backflow pressure on the Bowman's capsule, and then this decreases the GFR and causes acute kidney injury. Whenever this obstruction is relieved, usually the acute kidney injury settles down. What is the classification? KDIGO is the latest criteria used to classify acute kidney injury. It is divided into 3 stages: stage 1, stage 2, and stage 3, where it is based on the serum creatinine level and urine output also. Basically, if the serum creatinine is more than between 1.5 to 1.9 times the baseline creatinine, then it is called stage 1. And at the same point, if the urine output is less than 0.5 ml per kg per hour for around 6 to 12 hours, that is also stage 1 based on urine output. Stage 2 is 2 to 2.9 times the baseline, and based on urine output, it is 0.5 ml per kg per hour for more than or equal to 12 hours. Then it is also called stage 2. If the creatinine is more than 3 times the baseline, or increase in serum creatinine to more than 4 mg per dl, or patient is initiated on RRT, it is called stage 4. In patients less than 18 years, decrease in eGFR to less than 35 ml per minute is considered as stage 4. And in stage 3, based on urine output, if the urine output is less than 0.3 ml per kg per hour for more than 24 hours, or if there is anuria for more than 12 hours, it is called stage 3. These are the various comparison of various criteria over years, which were over the years, which have been improved. Initially, rifle was followed by acute kidney injury network criteria, then the KDIGO. KDIGO combines both the akin and rifle slightly, and almost all of them almost are the same, except that the urine output part is added in the KDIGO. And as you can see, there's not much difference in the rise in creatinine in stage 1 for either rifle, akin, or KDIGO. Only the even the duration is also the same. Only there is a mild change in the values, like 2.9 times the more than 1.5 times is the definition. Stage 1 is 1.59 times, which is in all of them. Here, rifle and akin, it is in the both. Whereas in stage 2, it is 2 to 3 times, which is almost the same as all of them. Next. Then, what are the important points to see in acute kidney injury? What are we, whenever we see a patient, what are we dealing with? So basically, we should know that first we have to deduce who are the patients at risk. For example, a patient diabetic, or patients having a background renal disease, or the patients having background autoimmune conditions are at risk patients, or patients having chronic anaesthesia are also at risk patients. Or these patients who are at risk might be in the subclinical phase of the AKI, which might be found out by biomarkers like TIMP and NGAL. Then comes the AKI stage 1, stage 2, and stage 3. And nowadays, a new terminology has been started that is called the acute kidney disease, which bridges the CKD and acute kidney injury, which is from 7 to 90 days. Beyond 90 days is called CKD. Even acute kidney disease follows the same criteria as the KDIGO. This is a brief insight into how acute kidney injury, AKD and CKD, where acute kidney injury either with a normal kidney, then progressing to acute kidney injury, it might progress to acute kidney disease or CKD, or it might recover, as these green arrow marks indicate. So AKI progressing to AKD and CKD, or there might be recovery en route. These are the possibilities. And after the CKD, it might be end-stage renal disease or cardiovascular complications and death. So we have to note down the timeline. First 7 days it is AKI. Between 7 to 90 days it is acute kidney disease. More than 90 days it's CKD. This is a pathophysiology of acute kidney injury. Basically, what are the factors contributing to the acute kidney injury? Like fall in GFR, which is one of the major, which will always be a reversal AKI, which might be due to damage by a pathogen or drugs which can be stopped, or patient might be having baseline risk factors which we have to keep in mind and be careful in choosing the doses of medicines. And at the same time, patient might have tubular injury also because of the pathogens, infection, drugs, everything. So usually GFR and tubular injury might occur, or both might occur and cause AKI, and from then on there will be progression. If both are in severe form, then that will progress to AKI. That AKI progress to AKD, CKD, based on if AKI there is resolution, then there will be recovery. If there is no resolution, then it might progress to CKD and fibrosis, and we have to see the biomarkers. The endpoint is either there is full recovery or subclinical renal scarring, or CKD, or end-stage renal disease. Whereas as you can see, even AKI is caused by venous congestion seen in cardiac patients and cardiorenal syndrome, where it will be a low cardiac output state causing hypoperfusion, causing both tubular injury and fall in GFR. For tubular injury, biomarkers help a lot, and they might help in detecting early and doing the necessary protective strategy. The KDIGO bundle. What is this bundle? This is early optimization of fluid status, maintenance of perfusion pressure, discontinuation of nephrotoxic agents. What are the various treatment modalities available? First and foremost is the diuretic therapy, the diuretics, and dopamine of late has gained importance, especially in the cardiac setup, where it stimulates the D1, D2 receptors and causes natriuresis, as well as causes afferent arterial vasodilatation. And as all of us know, renal replacement therapy, it might be intermittent hemodialysis or continuous renal replacement therapy, which might be slow continuous ultrafiltration, continuous veno-venous hemodialysis, continuous veno-venous hemofiltration, continuous veno-venous hemodiafiltration. Arteriovenous hemofiltration, it's not done nowadays, very rarely. Slow, low efficiency daily dialysis is also done, which is also gaining a lot of importance, and many people are preferring this. And peritoneal dialysis is done, but very rarely. Next is I spoke about the diuretics. I'll just brief insight into what all diuretics we might be dealing with. Basically, first and foremost, the water is an important diuretic. The water content in the body decides whether the ADH needs to be secreted or not. If water is in good content, the osmolarity of the blood changes, and if osmolarity is low, then it stimulates osmolarity is high, it stimulates the vasopressin for vasopressin release and causes this thing. If water content is high, it inhibits ADH. Similarly, there are many osmotically active substances called mannitol and glucose, which promote osmotic diuresis. They cannot be reabsorbed within the tubules, and hence they increase the osmolarity of the tubule and cause reabsorption of water. Similarly, metolazone and thiazides help in work as a diuretic by inhibiting the sodium chloride cotransporter in the early portion of the distal tubule and cause diuresis. Loop diuretics, furosemide is the most common one we use, and this inhibits the sodium potassium 2 chloride cotransporter at the medullary thick ascending limb of loop of Henle and cause diuresis. Similarly, potassium sparing diuretics like aldactone, etc., they act by inhibiting the sodium potassium exchange in the collecting ducts and also at the E-sodium channels. Thank you.
Thank you, Siddharth, for your talk. Over now to Dr. Hemanth to take over the next.
Thank you. I have the pleasure of introducing Dr. Abbas, who is a dynamic young intensivist. He's a junior consultant in adult cardiac unit in Narayanadhyalaya, and he'll be speaking on biomarkers in acute kidney injury. Over to you, Abbas.
Thank you for introduction, sir. So next 15 minutes, we'll be discussing about the biomarkers in the acute kidney injury. So what is a biomarker? Biomarker is a thing which is objectively measured, which is an indicator of the either pathological or biochemical process. So coming to acute kidney injury, as comparison with acute myocardial infarction, in terms of biomarker, so in 1960s, it started with measuring the LDH level for the acute myocardial infarction, where for the acute kidney injury, we used to measure serum creatinine. As we evolved in the 20th and 21st century, we moved out for acute myocardial infarction from LDH to troponin 3 and troponin I, which reduced significant mortality to 50 to 70% by use of various therapies. Whereas for acute kidney injury, it is still the creatinine which we are using, which also has high mortality in case of ICU. Okay. What are the drawbacks of the serum creatinine? It has a lot of drawbacks. One thing is a lot of things affects the serum creatinine level. One could be extracellular volume depletion, decreased kidney blood flow, age, sex, body mass, and nutritional status. As well as serum creatinine is not a specific or sensitive marker. Specific means it does not differentiate between pre-renal, post-renal causes or ATN related causes. It is neither sensitive because it takes longer time. Usually it takes 48 hours for it to appear, for it level to be elevated once the acute kidney injury happens. So if you compare with the newer onset of biomarkers like NGAL, once the acute kidney injury sets in, it is elevated within 2 hours of the acute kidney injury. Whereas in case of serum creatinine, it takes 48 hours for it to increase in the level of the serum creatinine. Hence, we miss out 24 to 48 hours of the critical therapeutic window for the treatment or therapeutic modalities. Why is it important to measure what are the roles of the novel kidney injury biomarkers? One could be it is for the early detection of the AKI in case or early rejection of the post-transplant recipient or early occurrence of the other diseases in case of post-kidney transplant. It also used to differentiate between various causes of the acute kidney injury like pre-renal causes, post-renal causes, or it could be sepsis or contrast-induced, or it could be related to post-cardiac surgery, or it could be related to obstructive or urinary tract infection. These novel biomarkers also helpful for evaluating and understanding the prognosis of the disease in terms of how is the long-term process, whether the need of the renal replacement therapy as well as predicting the risk for CKD progression. More than 20 protein biomarkers have been intensively studied. So most importantly, urinary biomarkers are ideal because these are non-invasive, it is easy to measure and easily obtainable. Hence, it provides earlier detection for the AKI. So yeah, urinary biomarkers are classified into both biomarkers of the structural injury and biomarker of the functional injury. The new biomarkers of the structural injury includes kidney injury molecule 1, that is KIM1, NAG, that is N-acetyl glucosaminidase, and NGAL, that is neutrophil gelatinase associated lipocalin, and interleukin 18 clustering, or nephrocheck, that is TIM2 and IGF-BP7, whereas the biomarkers of the functional injuries are cystatin 7, total protein tau microalbumin, and other biomarkers. Among these, so we'll be discussing KIM1, NGAL, and interleukin 18 and cystatin, because these have gained importance in the recent studies and literature. So most of these biomarkers are elevated 12 to 4 days prior to the detectable rise of the serum creatinine. Hence, these are very important. The other biomarkers also has been studied. So these are the names. We'll not be going through all this in detail. Okay. Coming to few important biomarkers. Coming to NGAL, that is neutrophil gelatinase associated lipocalin. This is most consistent biomarker found in during AKI. This is found in the proliferating nuclear antigen positive proximal tubule cells. So it predicts occurrence of AKI in pediatric as well as adult patients after cardiac surgery. It also predicts the morbidity and mortality in children who undergo cardiac surgery. So there are various available methods for measuring NGAL. That is, one is the ELISA method and plasma NGAL kit. ELISA method usually has a long turnover time, whereas urine NGAL and plasma NGAL have a turnover time of 20 minutes. Coming to NGAL score. So after measuring the NGAL, based on the level, it is classified into 0, 1, 2, 3. So basically, this classification is for urinary NGAL as well as plasma NGAL. Approximately like for urinary NGAL and plasma NGAL, level less than 100 nanogram per ml is 0. That is tubular damage unlikely. Level 1, that is the level between 100 to 200 is there might be a possibility of tubular damage. If the level is between 100 and 1000, there is definite tubular damage. If the level is more than 1000, there is severe tubular damage. Okay, there are various studies have conducted that as the AKI incidence increases, the level of the NGAL increases. It has a good sensitivity of 100%, specificity of 75%, and good positive predictive value of 100% and negative predictive value of 75%. So coming to how we can use NGAL as a algorithm-based approach. So when the patient gets admitted for the surgery or waiting for the ICU admission or comes to emergency department for the treatment, there are risk factors for the development of AKI. In that case, we have to measure the NGAL levels. Then we have to classify depending on whether it will, depending on the NGAL levels, either it is 0, 1, 2, 3. 3 is a severe tubular damage. If somebody is having 0, that is less tubular damage is unlikely, then the patient can be safely treated on the OPD basis or safely treated in the ward. Whereas in case of level 1 and 2, it requires to admission for the step down ICU and management. Whereas level 3 involves admission to critical care intensive unit and management of the AKI in the critical care intensive unit, the probably requirement of the renal replacement therapies. These are various studies which are conducted on NGAL in case of measuring and predicting the AKI in cardiac surgeries, in ICU, as well as contrast-induced AKI. There is good evidence that it predicts the onset of the AKI as well as the use for the renal replacement therapy based on the levels. This is the same NGAL which was conducted in NH by Muralidhar sir, which also concluded that NGAL levels were higher in patients who had a AKI. Similarly, NGAL also studied in patients with liver injury in hepatorenal syndrome, which also has a good sensitivity and specificity and positive predictive value. Coming to second injury markers, that is kidney injury molecule 1, KIM1. This is a transmembrane receptor of unknown function, undetectable in normal kidney tissues or urine. It is markedly increased in ischemic, nephrotoxic, and proximal tubular injury and renal cell carcinoma. Higher urinary KIM1 is associated with worse outcome in established case of AKI. Okay, this can also be measured in nanogram per ml. So on comparison with creatinine and NGAL, KIM also has a good sensitivity, specificity, and good positive predictive value. And KIM1 is a molecule where we can differentiate between AKI and CKD. See, in AKI, the levels are much more higher than CKD. There are good studies which tells that KIM can be used as a predictor for acute kidney injury in cases of ICU, in cases of drug-induced nephrotoxicity, and in chronic type 2 diabetic patients. Coming to third biomarker, that is interleukin 18. It is a pro-inflammatory cytokine. It mediates inflammatory process. It is basically based on the recruitment of the neutrophils during the ischemic and septic phase of the AKI. It can predict the AKI 1 day ahead of the serum creatinine. It itself is an independent predictor of the mortality, especially in case of acute kidney injury along with the ARDS patients. So as we see, the interleukin 18 levels are increased in cases of patients who have AKIN 3 or more classification compared with the AKIN 1 and 2. Coming to fourth biomarker, that is cystatin C. This is cystine proteinase inhibitor secreted by all nucleated cells in the plasma, freely filtered in the glomerulus and not secreted in the tubules, less influenced by the factors like GFR. Therefore, change in the serum creatinine, urinary cystatin levels more sensitive than a change in the serum creatinine in predicting the changes in the GFR. So it directly tells us about the GFR, and it predicts the risk of AKI associated with cardiovascular morbidity. The increase in urinary cystatin C and alpha-1 microglobulin are predictor of unfavorable outcome in ATN. It has a high sensitivity and high negative predictive value for determining the GFR in CKD patients. This is a nephrochecks which can be used as a cartridge method. So it basically detects TIM2 proteins and IGF-BP7. This cartridge method takes approximately 20 minutes. It can be measured on the bedside also. This study was conducted in Narayan Vidyalaya by again Muralidhar sir, which also suggested that they concluded that early detection of the AKI in patients in a high-risk patient is a single value in this was not so much useful, but whereas trend of detecting this TIM2 and TIMP and IGF-BP7 was very useful in determining the acute kidney injury in patients who underwent cardiac surgery. So how can we use proposed biomarker as strategy for renal replacement therapy or predicting the AKI? Once the risk for AKI is present, we have to measure the biomarkers. If biomarkers values are less, then manage it conservatively. If biomarkers values are higher, then we have to classify clinically based on AKIN 1 and 2 and AKIN 3. If AKIN 1 and 2, then it's better to manage conservatively. Somebody with high biomarkers with AKIN 3 classification, it's better to consider for early renal replacement therapy, because early renal replacement therapy has more chances of kidney recovery. So coming to early versus late renal replacement therapy, for understanding renal replacement therapy, once we measure the NGAL level, cystatin C level, NAG level, KIM1 protein, and alpha-1 microglobulin level, if these levels are very much elevated, then it's better to consider for early replacement therapy. It reverses the kidney function early compared with a late renal replacement therapy. So take-home message should be, AK is the most common problem with serious short-term and long-term consequences. The most we should do early emphasis on early detection of the acute kidney injury, and goal should be early preventive and therapeutic measures should be taken to diagnose the acute kidney injury, to understand the severity of the disease, and to understand the requirement of dialysis, and also to predict the mortality. Thank you.
Thank you, Abbas, for a very lucid talk. Over to the Dr. Somnath Chatterjee is there. Over to him.
Is Dr. Somnath here? It's my pleasure to introduce Dr. Sunil Kumar, who is working as a consultant in intensivist in the cardiac intensive care unit of Narayan Hrudyalaya, a very enthusiastic worker and always learning new things and getting better every day. Dr. Sunil Kumar, I have the privilege of introducing him to you. Sunil, please start your presentation on RRT. He will be talking about renal replacement therapy. Sunil, can you please share your screen? Dr. Sunil Kumar, are you there? Can you hear me, first of all?
Sunil sir, you are muted.
Go to your first slide. Please go to your first slide.
So we'll be discussing, my slides are visible sir now?
Yeah, we can see it. It's clear.
Okay. So we'll be discussing regarding the renal replacement therapy. So it's following are the indications for renal replacement therapy. It's not the number which dictates us to go for renal replacement therapy. It is the rise in the total value and the clinical deterioration of the patient, which clinician has to take into consideration for initiating renal replacement therapy. So early versus late initiation of dialysis in acute kidney injury. So many of the trials has been done, which is showing there is no difference in the early as well as late initiation of the dialysis in acute kidney injury. Coming to the mechanism of solid removal, it can be done by filtration and dialysis. So you could see the picture A, where the blood is pumped to the semi-permeable membrane. So the small molecules the hydrostatic pressure, which is generated from the blood side, will be pushing the plasma to the other part of the filter by, the molecules smaller than 50,000 kilodaltons can be easily passed through the filter. The ultrafiltrate which is being produced can be discarded, and depending upon the condition of the patient, whether the replacement fluid can be added or not. Coming to the next figure B, which is dialysate. So here the blood is pumped. Here for dialysis, we need a dialyzer where we pump the blood into the dialyzer, and the dialysate is coming from the dialyzer. So here, majority it follows a fixed principle. That means to say it basically acts on the concentration gradient. So for example, substances such as bicarbonate will come into the blood, and substances such as creatinine, urea, H+ ions, potassium, all will come to the dialysate fluid. So the dialysate fluid has been taken out, and the efficacy of the dialysate, the ultrafiltrate membrane, will enhance, because we have to have we have to maintain a counter countercurrent mechanism. So it has to be in an opposite direction as to the blood flow. So these are the coming to the requirements of CRRT. We should have a double lumen hemodialysis catheter, which can be placed in the central venous axis. You need a hemofilter. You need a circuit, which will be using to draw the blood from the patient, and which will be pumping to the hemofilter. And then the ultrafiltrate will be taken out into the effluent bag, and we can connect dialyzer into the ultrafiltrate circuit. Then the blood which is coming out of the hemofilter will be returning back to the patient. So we have many modalities of hemodialysis. First of all, first we discuss regarding the intermittent hemodialysis. As you could see, the hemodialysis is being happening on the patient. We are drawing the blood from the patient, and that has been pumped into the hemofilter. Then the dialysate is being pumped from the other side of the dialyzer. So thereby the ultrafiltrate has been taken out from the patient. Usually in intermittent hemodialysis, the timing would be around 3 to 5 hours. The patients who are hemodynamically stable, we can do this modality for about 2 to 3 days, 2 to 3 times per week, so that their the waste products which has been created by the body will be excreted. Coming to the CRRT, that is continuous renal replacement therapy. Here, this has been used in hemodynamically unstable patients. So here, in intermittent hemodialysis therapy, the blood flow would be around 150 to 300 per minute. But here, it will be around 70 ml per minute. So you could see the hemodynamic instability can be maintained with less drawing of the blood. this is the picture which depicts the CRT. And here you could see we are taking the blood from the patient, and which is being pumped to the hemofilter, and the effluent ultrafiltrate which is being produced is being taken into the effluent pump. So in this, we can add the replacement pump fluid, either pre-filter or post-filter. Depending upon certain scenarios, this can be used. If you add the replacement therapy pre-filter, the chances of the need of anticoagulations will be lesser, and the ultrafiltrate will be much higher, and the hematocrit will be much less. Coming to the post filter replacement pump, here the concentrated blood will be coming, so the ultrafiltrate efficiency increases. Since the hemo concentration is there will be a clogging of the hemofilter, which needs higher anticoagulation. And you in this scenario, you don't need to add any kind of fluid. If the patient is, we need to make the patient negative. Next is slow continuous ultrafiltrate, that is SCUF. The same circuit, only here the blood is being pumped to the hemofilter and the ultrafiltrate is taken back. This modality is used in patients who are volume overloaded scenario, where only if you take out the volume, their clinical improvement will happen. Then coming to continuous veno-venous hemodialysis, here you could see we have added a dialysate pump into the circuit, where in this scenario, will be whatever the filtration will be there, it will be happening pretty slow compared to that of the hemodialysis. But here we can take out low molecular weight substances such as potassium, urea, creatinine, hydrogen ions effectively. And those things will be excreted as ultrafiltrate. Coming to hybrid technique, that is sustained low efficiency dialysis. Here, the treatment would be usually daily, but for longer sessions than compared to the conventional intermittent hemodialysis. Here, solute and fluid removal are slower than IHD, but faster than the CRRT. So hybrid therapy are the future of the RRT in ICU, but there is currently a lack of evidence to support its use. So we need to have an anticoagulation. The most common anticoagulant which we use is the heparin, which is at a dose of 40 to 70 international units per kg as a bolus, followed by 5 to 10 international units per kg per hour as an infusion. So if the patient is HIT positive, we will use bivalirudin. So if the patient is having a risk of bleeding, so we can't use the heparin. In that scenario, we can use regional citrate anticoagulation. So where you'll be adding sodium citrate, so that the calcium won't enter into the body and clotting won't happen. And the whatever the citrate is coming back into the patient, we'll be infusing the calcium near the post filter, so that the citrate toxicity won't happen to the patient. So the take-home messages. So which RRT modality should be adopted? So if you want to take out small molecular molecules such as urea, creatinine, potassium, hydrogen ions, or lithium, you should go for, if hemodynamically stable, then you can go for hemodialysis. Or if it is hemodynamically unstable, we can go for CVVH, or it can be used. If you want to take out middle molecules, that depends upon 500 to 5000, filtration will be better. Like you can use SLED or CRRT, especially CVVH can be used. For low molecular weight heparins, we can use CVVH, that is CRRT. You can use even SLED, which will take out cytokines and complement factors. Coming to water, which is around 18 Daltons, it can be used using SCUF, as we discussed earlier. So thank you. And I would request you to, we are organizing a CME called ECMO Fundamentals in our Narayana Institute of Cardiac Sciences. It is on the 23rd of September 2023. Please do register and please do attend. Thank you.
Thank you, Sunil, for that succinct presentation on the renal replacement therapy, and well done. Thank you so much. Please stay back till the end of the session because there may be questions which you have to address and participate in the ongoing discussion. With that, I will request Dr. Sanjay to introduce Dr. Girish for the next topic.
Good evening, everyone, again. Dr. Girish is a junior consultant working in the adult cardiac intensive care at Narayan Hrudayalaya. He will give you an insight over the next 15 minutes with regards to what our data is at NH, but this is limited to the post-op cardiac surgical population. Over to you, Girish.
Thank you, sir. Thank you so much. Hope I can finish in 15 minutes. Am I audible, sir?
Yes, I can hear you. Yes, I can hear you. Your slides are visible as well.
So I'll be talking about, we have a 40-bedded ICU where we purely take of the cardiac cases. And I'll be talking about the multi-factor analysis of the RRT requiring in patients who have undergone RRT for AKI. I don't have any disclosure to say. So I've collected data in the last 5 years from 2018 to 2023. So we have done approximately around 9,873 cases, out of which 226 cases required renal replacement therapy, out of which 188 were non-ECMO and 38 were ECMO. So the overall incidence of renal replacement therapy for AKI in a post-cardiac surgery in our setup in the last 5 years would be 2.2%. One went on to have a long-term hemodialysis, and I've excluded from this the cardiac transplant, lung transplant, the bivads, and also the patients, CKD patients who have been already on dialysis. So graphical representation of ECMO versus non-ECMO cases. ECMO cases were 17%, non-ECMO cases were 83%. So let's see the different type of cases what we have had. We have had about 27% of off-form CABGs, 26% of valve cases, usually replacement, repair, and 22% of the cases were surgeries of the aorta for dissection, dilatation, aneurysm, and CABG with valve cases were 13%, and other cases which included pulmonary thromboendarterectomy, myxoma cases, ventricular septal defect repair, and ASD repair, which constituted this 188 patients, and this is the differentiation. So use of CPB, yes, 70% of these cases were requiring CPVUs, and the off-term cases, which is around 27 to 30%, did not require CPVUs. So, but if you look at the overall incidence of AKI requiring RRT in the 9,800 cases, the incidence would be only at 1.38%. So this correlates with the journal in which an acute kidney injury and prognosis after CPV bypass, a multi-analysis cohort study where they included 258,000 studying the various articles. So there, the incidence of AKI requiring RRT after CPV was 2.1%, which is almost similar to our study. By looking at the comorbidities, diabetes were 17, hypertension and diabetes together, cases who required RRT is 45 patients. Diabetes, hypertension, hypothyroid were 9. CKD cases, these are cases where the creatinine will be slightly higher, but they did not require any dialysis in the preoperative stage. AKI, probably with an dye injection, their creatinine would have gone up, but did not require dialysis. Hypothyroid patients were 24 and nil patients were 45. As you can see, the comorbidities, hypertension, diabetes, and without comorbidities are similar or same. So that means people undergoing cardiac surgery, it does not depend on the comorbidities only. So with respect to age, in our cases, 64% patients were under 45, probably, and 45 to 64 were 25%, and less more than 65 were 11%. If you talk about CKD, yes, the age becomes a factor, but probably in our ICU, in our OT, the number of cases who got operated were between the less than the age of 45. Probably that is why the incidence of AKI requiring RRT is 64% in patients who were less than 45. Gender, usually they say that female predominance is there, but in our collection of patients, male predominance was there with 71%. So types of RRT, what we used, 11% of cases we used CRRT. HD was for 4% after the nephrology reference, and maximum what we follow in our ICU is SLED. It is a longer duration of SLED compared to other ICUs which they follow. We follow more than 12 hours of duration of SLED, what we follow here. Use of vasopressors. Use of vasopressors for hypertension or low cardiac output state, when the dialysis was initiated, use of vasopressors were high in 77% of patients and nil in 23% of patients. And use of vasopressors for dialysis-related hypertension is a risk factor for death itself, as shown in the study published in 2019. And it becomes an independent risk factor for death. So the most important slide, outcome. The patients, in the 188 patients who require dialysis for AKI, the mortality is 151, which is equal to 80%. And 116 patients had a 7-day mortality, and 17 extra patients had a mortality within 14 days, and an additional of 12 patients. So overall, around 130, 140 patients had a mortality within 30 days. The incidence is high, which is also correlates to, we do not know the exact cause why the mortality is high in our patients. When I looked at the mortality of outside studies, where we can see in 2011, where 6-year experience from a Poland study where they included 9,200 patients requiring RRT for AKI, the mortality was 58%. But in China, as the year progressed, in 1,587 patients, 18 required RRT. In that, the mortality was almost 66.7%. And in Lithuanian study, mortality prediction in patient requiring AKI, in patient with AKI requiring RRT after cardiac surgery, they included only patients after cardiac surgery were 111, and their mortality was also 76.5%. So Is it that patient going to RRT after cardiac surgery, the mortality is going to be high? Maybe that is the prognostic factor in this. So this is a study where they've compared between the CRRT with SLED. So in this is a case where they've done around 25,000 cases they have included. In this single center cohort study, the use of SLED for treatment of severe cardiac surgery associated acute kidney injury was associated with a significant lower cost while maintaining comparable post-operative outcomes. So basically they say is the outcome did not matter whether they have put on SLED or CRRT. So why SLED? So average duration of dialysis in our patients were 7 days, consider, and cost of each CRRT cycle with all the equipments, nursing charges, doctor charges, and everything would come up to 30 to 36,000 per day. Cost for a SLED for an 18-hour cycle, what we follow, is 6,000 to 8,000 per day. So basically what we do is 6 days or cycles of SLED in the cost of one CRRT. That's how cost efficient a SLED can be. We have had certain complications like vasopressor requirement, hypertension, and the solution for diastolate what we use is a dextrose-free solution. The reason for that is the more dextrose in the diastolate solution causes more chance of infection. So when we use a no dextrose solution, the chances of hypoglycemia are high, and in our case, 57% patients required dextrose supplement during their SLED or dialysis. So renal replacement therapy and hypoglycemia, retrospective study was conducted, which concluded that hypoglycemia is a frequent complication noted during CRRT. Frequent blood glucose monitoring should be included in the CRRT protocols to prevent such effects of severe hypoglycemia. We also noticed that putting a patient on SLED or for a long duration of cycle causes thrombocytopenia. Yes, thrombocytopenia was noted in 52% of patients where they had to be given platelet transfusion. Our cutoff value is 1 lakh. 1 lakh, below 1 lakh, we tend to transfuse them with platelets. We should also remember here that the chance of HIT, heparin induced thrombocytopenia, is also high in such cases. Our incidence is 7%, and we should never forget that heparin induced thrombocytopenia should always be at back of your mind. And whenever there is thrombocytopenia with patient receiving heparin for more than 5 days, we should always send for HIT antibodies. So this is a study published in 2019 in Critical Care Medicine, which shows effects of baseline thrombocytopenia and platelet decrease following RRT in patients with severe acute kidney injury. So there is also, since we have to be putting patients on hemodialysis catheter for AKI and putting them on long duration of dialysis requiring probably multiple days, probably 10, 14 days and all. Obviously, catheter-related infections are very high. And out of all the data I could collect, we had 60% of cases where there were no growth. 60% of blood cultures did not have any growth. That means sepsis might not be a concern where patient having dialysis for longer duration. Our most common pathogen was Klebsiella pneumonia, which was seen in 14%. So evaluating approaches for diagnosis of hemodialysis catheter-related bloodstream infection, I found a study where 2001 to 2014 catheter-related bloodstream infection was noted, and patient with HT catheter undergoing dialysis, 100 samples were taken, and 58% culture had no growth, which is similar to our study where 60% did not have any growth in blood cultures taken from the dialysis catheter. Our protocol of taking culture was is whenever we put in every 6th day, we change the dialysis catheter, and 7th day, and when we put a new dialysis catheter, we take a culture from that. So overall take-home message from my side, from all my team would be through this extended SLED, what we do is an 18-hour cycle, is an effective as CRRT as an RRT tool in the postoperative period. Mortality remains high in the RRT cohort following after AKA in a postoperative cardiac case. HIT can occur in patients undergoing RRT. Please keep an eye. Hypoglycemia is notorious in patients. We have had cases where patient developed seizure activity because of hypoglycemia during dialysis, and sepsis and morbidity from sepsis no different in the ICU cohort with patient requiring RRT or non-RRT patients. Thank you.
Thank you, Girish, for a very lucid presentation and sticking to time as well. Over to
thank you, sir.
Over to Hemanth for taking on the rest.
Okay. Next speaker is Dr. Muralidhar. He doesn't need any introduction. He is a very senior and accomplished academician, senior consultant and professor of anesthesia, and he'll be speaking on genetic predisposition in AKI. Over to you, sir.
Thank you for the kind introduction. Can you see my slides and hear me?
Yes, sir.
That's great. In the next 15 minutes or so, I'll be dealing with the subject of genetic predisposition to kidney injury. And I'm just trying to figure out the pointer. One second. One second, give me 1 second. Ladies and gentlemen, I'll be speaking to you about the genetic susceptibility to acute kidney injury with special reference to cardiac surgery. As already pointed out, acute kidney injury complicates cardiac surgery in about 30 to 40% of the patients. And those patients who need renal replacement therapy because of acute kidney injury following cardiac surgery, the mortality rate is close to 50%. Actually, my previous speaker said it is 70 to 80%, and I totally agree with him that the mortality rates are as high as 80% in some series. So it is essential for us to know why some people develop acute kidney injury following cardiac surgery. They come for cardiac surgery, but go back with a either they die because of renal complications, or they need renal replacement therapy for lifelong. This is a factor which we need to consider. And it appears that it is amply established that the incidence of acute kidney injury in Caucasian population as compared to African Americans and Indians is much different, and there is certainly some genetic component attached to the development of kidney injury. An estimated 1 million patients undergo cardiac surgery every year worldwide. And India, the estimated guess of number of cardiac surgeries done is about 150,000 patients. As I already said, up to 20 to 30% of them develop acute kidney injury. And if they need renal replacement therapy, the mortality rate is very high. A combination of factors are responsible for the development of acute kidney injury. It is not a single factor. This can be classified as preoperative factors, which includes, preoperative risk factors, which include congestive heart failure, reduced ejection fraction, long-standing diabetes, COPD, peripheral vascular disease, use of IABP, and emergency cases and cardiogenic shock. Coming to the surgical factors, we have the long CPB time, which is usually non-pulsatile, long cross-clamp time, hemodilution, transfusion load, and use of hypothermia. Post-operative risk factors include hypotension, sepsis, nephrotoxic, and low cardiac output states. If you look at the rise of serum creatinine, I'm sorry, this pointer is not working, so I'm not able to use it. But anyhow, you can see that this the magnitude or rise of serum creatinine is dependent upon the magnitude of the insult the patient is undergoing when we operate these patients. The yellow boxes indicate the average peak in that particular disease group, and the blue or circles represent the daily average creatinine. And on the vertical axis, you have the percentage of increase in the creatinine. If you carefully observe, each of these blue circles represent one day, the average on that particular day. If you take the baseline for each of these groups, most often on the first post-operative day, creatinine level actually falls, and then it rises on the second, and then maybe third post-operative day. And depending upon the degree of the insult, it stays elevated for a couple of days and then comes down and settles down at the baseline level by the end of the week. So the reason for the decrease in the serum creatinine just after surgery is that there's a lot of hemodilution happening, though the renal function may be impaired because of the surgical insult, because of the hemodilution, and also the fact that my colleague Dr. Abbas was saying that it's a late indicator. It takes 24 hours for it to rise in the face of kidney injury. So that's why you don't see the creatinine rise immediately. Coming to the genetic polymorphism, which can be associated with kidney injury, it is clear that the clinical factors alone do not dictate or do not indicate that there is going to be a post-operative renal injury. This study was published first in 2005, which indicated that in African Americans, as compared to Caucasian, there is certain genetic components which are responsible for occurrence of renal dysfunction in African Americans much more than the Caucasians. Actually, it was 3 to 5 times greater in African American population. And that is about American population. What happens to Asian population? Asian population also, they have shown that there are markers of genetic markers which may indicate the occurrence of acute kidney injury much before the insult actually has started. The crux of the problem is if you take two individuals and subject them to the same stress level, these individuals may react differently to the stress. One may suffer kidney injury, but the other may not. So this is because of the genetic differences. And this slide also shows that in the Asian population, the genes which are responsible are different from those who are responsible for acute kidney injury in white population. And this is a schematic representation of the genome it's a schematic representation of a typical human gene with locations of gene polymorphism. You have the promoter and the core and transcription initiation, and then it goes on the exon and the intron, and actual transcription occurs, and then the polymorphism occurs that may be responsible for differential manifestation of reaction to stress injury. For example, surgery, be it cardiac surgery, especially we're talking about cardiac surgery and the bypass. And we have the role played by the tumor necrosis factor and the angiotensinogen receptors, which may be different in patients who develop acute kidney injury when they are subjected to the stress of cardiac surgery and anesthesia. In our own little workup, about 2,000 patients were taken. Actually, out of the 2,000 samples, 800 had no symptomatic heart disease nor kidney disease. That formed the group C. I'm trying to get the pointer here. that formed the group C, and the other three groups, A, B, C, had the group A had no renal dysfunction to start with. Group B had patients who had renal dysfunction but did not require hemodialysis. They were undergoing off-pump CABG. And group C patient had renal dysfunction without obvious cardiac disease in terms of normal ECG, normal echocardiography, and no cardiac symptomatology. And D group patients were normal population who were undergoing routine health checkup where there was no discernible kidney or heart ailment. And all these samples were subjected to genetic analysis. This is the breakup of the cases. And the flow of the study was like that. DNA was genotyped. 4 ml of blood was taken and was subjected to global genetic assay using the equipment which is shown on the right side of the diagram. And KidGo guidelines were used to identify AKI in groups A and B, who were the patients who were undergoing off-pump CABG. These findings were presented to the American Society of Anesthesiologists a couple of years ago. And what we found was that there is indication that genetic polymorphism plays an important role in development of AKI in patients undergoing off-pump CABG. And this identification of this genetic polymorphism may pave the way for the development of novel biomarkers, preventive strategies, and designing treatment algorithms. And these are the results of the study. There is clear-cut evidence to show that in the chromosome 11 on the right top panel, where you have bars of blue and a bit of green, if you look at the 11 chromosome, which is shown on the horizontal axis, there is an indication that some of these polymorphisms are exhibited on this chromosome, and this has been again demonstrated in this slide. And we also subjected these patients' blood for looking at polygenic risk score for development of coronary artery disease. There was no relationship between the acute kidney injury biomarkers as in terms of genetic polymorphism when correlated with the polygenic risk score for coronary artery disease. The polygenic risk score for coronary artery disease is again a genetic test which can predict with 90% accuracy that an individual is likely to develop coronary artery disease irrespective of his or her age. You can take a blood sample at the age of 10 or 15 or 20, and you can predict what is the risk of coronary artery disease in that particular individual in the forthcoming years. So that scoring was also used to correlate if the polymorphism which causes kidney injury are associated with this polygenic risk score, but we could not demonstrate any such association. So this study is probably first genome-wide association study analyzing predisposition for AKI in Indian population undergoing off-pump CABG. This study showed that there is a polymorphism in the chromosome 11 in the position Q13.1, which may be an indicator that such patients may need strategies to prevent occurrence of renal disease, renal complications or renal dysfunction during surgery, if they need a surgery at all. And this confirmation of these findings must be done in a larger population. And as I said, there was no correlation between the polygenic risk score causing coronary artery disease and the genetic predisposition to acute kidney injury. With that, I would like to thank you for being with us. And I think I request Dr. Sanjay, Dr. Hemanth, and Dr. Somnath to take over the question answers and start the discussion. I'm just trying to share this one.
Thank you all for very lucid presentations. The floor is open for any questions, any discussion, any comments at all from the audience, and we will try to answer as best as we can. So there was one question in the box which I had answered earlier, which basically wanted to know the difference between the flow rates in SLED and SCUF. And the answer to that is there's no difference between the two. Both of them usually start at a dose of 150 ml per minute of blood flow. And the difference between SLED and SCUF is basically SLED causes removal of solute, whereas SCUF causes removal of water. So that's the only difference. Apart from that, the blood flow is primarily the same. The nomenclature for blood flow is QB, what we use in dialysis language. But apart from that, there is no difference with regards to your machine modalities in both the therapies. There is any other questions from any other participants?
Dr. Ratan Gupta is there in the meeting. I saw him. Ratan, you want to make any expert comments? Dr. Uma Hariharan.
Hello. Good evening, sir.
Yes. Sir.
Very nice presentation. Just wanted to ask, what are the preventive strategies which are well proved and which can be used during cardiac surgery so that we can prevent occurrence of kidney injuries? Any medicines or pharmaceuticals? I think it's an open question.
So we'll start with Siddharth. You want to take that question? Dr. Siddharth is there? Siddharth Raju? Abbas, Sunil, Girish, anybody wants to take on that question? What are the preventive strategies? See, as far as I am concerned, the maintenance of the circulatory blood volume and maintenance of mean arterial pressure are the most vital things to preserve renal function. Having said that, in patients who have cardiac disease, CVP also plays an important role in controlling the renal perfusion pressure. Renal perfusion pressure is dictated by the mean arterial pressure minus the central venous pressure. And if CVP is high for any reason, the kidney perfusion may suffer despite the fact that the mean arterial pressure is being maintained okay. So these are the two important aspects of patient care, the maintenance of intravascular volume and the driving pressure. These are the two most important aspects of patient care when we talk about renal preservation. There are several pharmacological agents and other things which have been proposed, but none have tested stood the test of time. For example, phenol-dopam and dopexamine and these urinary natriuretic peptides. Several agents have come and they have not really become the guideline recommendations for the use in routine patients to prevent acute kidney injury. And of course, you have to avoid nephrotoxic agents and delay the cardiac surgical intervention by about 48 to 72 hours after contrast agent has been used, especially if the serum creatinine has gone up following that. You have to wait for the creatinine to come down. So these are some of the factors which I would like to easily say on this aspect.
That was a very nice summarization, sir. Just to add, this is unpublished data. There are a few other studies which also support that. Vexus has got some role as well, which basically again reiterates the fact that
central venous
venous pressure.
So,
so in case,
yeah, that's right.
Yes, sir. So if the Vexus score is on the higher side, if it's flow reversal, that's an independent factor which can be associated with the increased instance of acute kidney injury.
That is true. And the other one which is mentioned in textbooks is the how much hematocrit can go down on bypass. It has been proven without any doubt that if the hematocrit falls below 20% on CPB, the incidence of acute kidney injury is high because of the fact that the medulla is the most vulnerable portion of the kidney for hypoxemia. It is always in the borderline hypoxemic zone, even in health. So when you're reducing the hematocrit to less than 20%, medulla probably suffers most, and you get acute kidney injury after the surgery. Thank you.
I would like to add one more thing, sir.
Yes, yes.
Use of colloids and low chloride solutions are also risk factors for AKI following post-cardiac surgery, and probably excessive diuresis, keeping them more hypovolemic, are also risk factors for.
Yes, yes, that's what I said, volume status.
Yes,
that's
sir.
the bottom line in volume status.
Murli,
Dr.
sir?
Minati Chaudhary, Minati, you want to say something? Uma Hariharan is also there. They're all experts.
Sir, no, I'm not expert, sir. I just want to know from you. Suppose the genetic casualty is very strong and with a full penetrance for the patient developing renal failure. In that case, what will be the advice?
See, we have not looked at that, but if there is a genetic predilection, we have to see whether we can offer non-surgical options to that patient. Okay, and sir, if surgery is mandatory, then you have to keep all the factors which maintain the renal perfusion pressure, do minimum possible, go for minimally invasive techniques wherever possible, and if possible, avoid CPB. We have also published our results that off-pump is better in the presence of renal dysfunction. That is published, one of our papers showed that maintaining pulsatile flow during CPB or maintaining pulsatile flow because of off-pump technique may be important in these patients.
Suppose the patient is having congenital heart disease in which CPB is essential.
Congenital heart disease and there is strong genetic predisposition. We have to, you have to weigh the risks and benefits and offer the surgery if that is more important.
Okay, sir.
And then if necessary, use dialysis early so that the whatever things can be reversed, because the first speaker said that acute kidney disease can become normal kidney if you take care of the kidney properly.
Yes, sir. Thank you, sir.
Sir, we have a question from Dr. Balakrishnan.
Yes, sir.
Yeah, sir is asking, when would a critically ill patient be considered for dialysis? Any cutoff values of creatinine, urine output, or biomarkers for dialysis? What we do is we follow a protocol of as the urine output drops, even with fluid resuscitation or diuretics, if it does not improve, then we usually initiate the dialysis as early as possible.
It's quite an interesting question. You know, it's got multiple facets to that, in the sense that when you look at a critically ill patient, it basically boils down to the clinician's appetite for destruction, as you would call it. Now, basically, if you look at a renal marker, it would be hyperkalemia, which is the indicator for dialysis initiation. Yeah. However, it will also be driven by the fact that what subset of patients you are catering to. For example, in a cardiac surgical population, we get very worried when metabolic acidosis sets in. So when we start seeing a base excess in excess of -5, we start getting very twitched. Again, that appetite would differ in different intensive care units catering to different surgical populations. Fluid balance is a very big thing in cardiac surgical population. So we like to run them a little dry, not bone dry, a little dry. However, when we see oliguria setting in, that, in our opinion, is probably the best time to start thinking in terms of RRT. Because once the patient becomes anuric, the chances of that kidney coming back eventually starts getting lesser and lesser over time. So we normally would initiate RRT, when we start oliguria setting in. In our terms, 0.5 ml per kg per hour or below. That's what we would classify as oliguria. But apart from that, we wouldn't be driven by creatinine per se to initiate dialysis. Like you all know, creatinine takes about 24 to 30 hours for it to actually rise. And creatinine is also directly related to muscle mass. So if you have somebody who's got a very poor BMI, the rise of creatinine is going to be very different from somebody whose BMI is over 30. Now, this is very clearly reflected in the Cockcroft-Gault formula, where the body weight plays a very big differential in the final number which is arrived. So creatinine per se goes out of the window. That is not a marker for dialysis. However, blood urea becomes a marker. A high blood urea of greater than 150 milligram per deciliter automatically shows that you are in a state of cellular dehydration with the fluid being in the wrong places. So that becomes a marker for dialysis. However, creatinine per se is definitely not a marker for dialysis. I hope I've clarified Dr. Balkrishna's questions on that.
Yeah, I agree with what all you said. Urine output, anuria, oliguria, blood urea, metabolic acidosis, hyperkalemia, and also hypernatremia of more than 160 may be included in that list. So that's...
To add on to one thing, somebody asked biomarker. So NGAL has been extensively studied, sir. Usually the levels, if you more than 1000 nanogram per deciliter, indicates that the patient, high chances of patient requiring renal replacement therapy. The thing is, if we delay the renal replacement therapy, there is something called organ cross toxicity. Whatever the microtoxin which were removed by the kidneys, it will get delayed and it will injure the other organs. As Sanjay sir said, it's better to initiate RRT as early as possible. So if you measure the biomarker, ideally the NGAL level, if more than 1000, if you see Akin criteria more than 2, then you can consider for early renal replacement therapy, which might prevent the other organ injury because of the toxin.
Thank you, Abbas, for pitching in with additional points. Thank you so much. Are there any other questions, any comments? Are there any other questions? If there are no more questions, we may close the session after vote of thanks by the President of Indian College of Anesthesiologists.
So there are no more questions. Any other question?
That brings to the conclusion of this short and sweet webinar on renal dysfunction in critically ill patients. Thank you so much for joining. Now I request Dr. Jayashree Sood, who is the President of Indian College of Anesthesiologists, to propose vote of thanks, and then we can disperse for our dinners. Thank you so much.
Thank you so much, Dr. Kanchi. And I would like to congratulate your whole team for this excellent webinar. The topic, first of all, was so, interesting, and especially coming from all of you who are practicing cardiac surgery, because we've discussed AKI so many times in so many forums, but especially in critical care. And then we have got aspects of after cardiac surgery. It was really immense, and it was very, very, very knowledgeable. And you covered all your topics related to the AKI, right from pathophysiology to biomarkers to RRT, and RRT after cardiac surgery, and then of course the genetics. And I would like to thank all the faculty members who joined, the moderators, Dr. Sanjay, Hemanth, and Somnath. Thank you so much for taking out your valuable time and enriching us and with your moderation. And the lectures by Dr. Siddharth, Mohammad, Dr. Sunil, Kumar, Dr. Girish, and of course, none else but Dr. Kanchi. Thank you so much. And we all enjoyed. The interaction was so good. And we hope to see you all sometime on the forum again. Dr. Kanchi, see you next week. Thank you so much, Shreyashi. Thank you so much. And good night, everybody. Thanks a lot.
All invited for a virtual warm dinner. Thank you so much.
Thank you. Thank you very much.
Good night.
Bye-bye.
Thank you so
Good
much,
night.
everyone. Thank you
Bye,
so much
Shreya.
for,
Bye.
yes, ma'am. Thank you so much for giving us the opportunity to host the session. Thank you.
Thank you.
Thank you.
Good night.
Good night.
Thank you very much. Thank you. Good night, Baljit.
Very good night, ma'am.